Professors and fellow colleagues. My name is Leung Pak Ho, and this is my GPS project, Learning for Lifesavers, applying the principles of H-EDRM in humanitarian medicine. Originally, I did not know much about H-EDRM, as Hong Kong was a relatively disaster-free area. However, it is through my interaction with the NGO Refugee Union that I understand the impacts of disasters expand beyond borders. And with factors such as climate change and volatile international relations, these disasters are only expected to increase and worsen in the future. Hence, as doctors, we should not limit ourselves to the confines of Hong Kong when trying to help those in need. Hence, I dedicated my GPS project to achieve three main goals. Firstly is to analyze and appraise the current H-EDRM workforce training protocols. Secondly is to apply the H-EDRM principles through volunteering, humanitarian work, and also hospital attachments. And thirdly is to reflect on any personal growth and insights gained throughout this project. In Professor Hung's research project, Mapping Study for Health Emergency and Disaster Risk Management, Competencies and Curricula, Literature Review and Cross-Sectional Survey. This study aimed to understand do the current competency models and curricula match the WHE core competency domains and comprehensive emergency management and risk-based approach of H-EDRM. I compared the two curricula listed below. Between the two, we realized that the former emphasized on risk, capacity, population needs assessments, and also effective leadership, teamwork, and the necessary management skills for disaster risk management in their model. The variability that are observed between the two supports the need to create a universal framework for different agencies to reference. This can aid them in designing their disaster workforce competency curriculum, as it would encourage them in designing ones that are holistic and translatable, without sacrificing the unique optimizations that they have for their target audience. This is a possible direction for investing our future research efforts. I took the initiative to go abroad to Arusha, Tanzania for a 2-week hospital attachment. There, I hope to learn how a country with different health needs and demographics utilizes a different approach to public health interventions and their implications for H-EDRM practices. For HIV, I noticed how their disease prevalence has dictated their approach to combating the disease. Furthermore, we recognize that there's less stigmatization of the disease, possibly due to its high prevalence and insufficient awareness. One of the more interesting experiences was my visit to a Maasai village. The ethnic group is known for roaming across the lands of Africa and their dependence on cattle for their livelihood. Witnessing their daily life made me realize that they are particularly vulnerable to climate change and disasters, as well as the difficulty experienced by policymakers when designing culturally adapted health interventions. It also shows that the people most in need are often the ones hardest to reach. Ironically, indigenous tribes of East Africa are not only not receiving sufficient assistance, but they are experiencing further marginalization through the indirect effects of globalization. This exemplifies the role H-EDRM can play for these marginalized populations by protecting and improving their preparedness and resilience to disasters. On the other hand, the prevalence of NCDs was also a surprise to me. The implication that this has for H-EDRM practices is that there is supporting evidence that people with NCDs are negatively impacted by disasters. For instance, the majority of mortality caused by disasters is indeed due to the insufficient care of NCDs after the disasters. It was also interesting to see an innovative solution to this by combining the management of NCDs with HIV and AIDS. This has several advantages, as they tackle the synergistic effects between the two diseases, and patients are more likely to attend screenings and the subsequent follow-ups. Its efficacy is supported by the INSET Africa study, which showed higher patient compliance. I attended the Community Outreach Project to Changchao organized by CCOUC and the GX Foundation. This outreach project exemplified the importance of involving multiple stakeholders. The involvement of the local tour guides and the Rural Committee of Changchao supports this statement because they made navigation around the island much more efficient, allowing us to reach more families. They were also able to help us develop rapport with the outreach families, which was extremely helpful in understanding more about their lifestyle and how the pandemic had impacted it. Their frequent involvement with the community also allowed us to know more about their health needs and hence helped us design the contents of the quarantine supply kits. I recently traveled to Laos with CCOUC and GX Foundation to attend their cataract blindness elimination project and dengue fever health assessment and education project. The cataract blindness elimination project made me think of how effective altruism can be incorporated into H-EDRM to maximize its benefits. Effective altruism is a recently coined idea that I came across from the book Doing Good Better. It aims to use evidence and reason to figure out how to benefit others as much as possible and to take action on that basis. The Cataract Elimination Project aligns with this idea for several reasons. Firstly, surgery is the only definitive cure. Secondly, blindness rates is almost 10 times higher in low to middle income countries compared to Western countries. Thirdly, the surgery is short, cheap, and is one of the basic surgeries that all ophthalmologists master. These factors ensure that a large amount of people in Laos can benefit from this project at a reasonable cost. On the other hand, I became more mindful of the educational levels and question design when performing outcome assessment surveys. To give an example, below is one of the questions that we designed. While the correct answer was D, all of the above, many of our patients picked a combination that did not fit the options that we provided. On the other hand, patients were less familiar with the idea of fractions, making them unable to understand the prevalence of hypertension in Laos. We should also minimize the use of photos considering our patients just had eye surgery prior to attending our health intervention. If these changes were implemented in future outreach events, we should be able to perform outcome assessments more effectively. While I gained a better understanding of H-EDRM, this project also made me grow as a person and reflect on what it means to practice humanitarian medicine. The trip to Laos gave me important insight into the determinants of health in populations. While the impact of cataract surgeries can be widely and immediately felt, the effects of our health education are harder to measure. The number of patients we reach were also limited. There is no way to assess their true retention other than paying them another visit. But perhaps what is most important that I learned is that health behavior is often ingrained and restrained by our culture, educational level, environment, social status, etc. It is hard to reduce your salt intake when all restaurants nearby serve salty food, or to quit drinking when most of your peers drink during gatherings. But that's not to say our work was futile, but a reminder that what we do is only a small cog in a machine. And for our work to be useful, it must fit into the grand scheme of the project. Hence, our education must provide health advice and knowledge that is culturally relevant, economically and environmentally applicable to the population. While working with the Hong Kong Red Cross, I helped them compile field mission reports to create meaningful scenarios for simulation and discussion during training. These experiences highlighted the importance of problem solving and decision-making skills. Sometimes, physicians are even forced to make decisions regarding the allocation of limited resources among patients. This went against my initial associations of altruism, righteousness, and morality with humanitarian medicine. However, it is exactly these decisions that make people on overseas missions grow and learn what it means to be a doctor. This renewed my perspective on humanitarian medicine, as personal growth in this area is about sharing experiences of pain and suffering with those in need and helping them slowly walk out of that difficult situation. This is the end of my presentation. Thank you.